Okay, so good to have each and every one of you with us. We are really excited for today's webinar. I'm going to actually start sharing my screen so that you can see the slides for today. Here we go. Let me start at the beginning. And I will want to also share my sound in a moment. Share sound too, and that one, great. Okay, can everybody see this?
Yes.
Great, okay. So welcome, my name is Kelly Olson, and I am so glad that you are with us this evening, whether you're with us live or watching this on recording. We just wanted to take a moment to say thanks for being with us. We celebrate you and the fact that you want to grow as a nurse practitioner and be able to grow your skill set. So we are so excited to have you here in the room. I want to let you know that you're going to be interacting with us. So have your chat open if possible. Feel free to grab a notebook or take some notes on your computer, whatever you'd prefer. And Dr. Oji is going to run through the top 3 tips for urgent care providers. And you're going to get a whole lot of information in a very short amount of time. So definitely have some notes ready. And then afterwards, we are going to wrap up with some Q&A. So if you are interested in being able to ask some questions afterwards, drop those questions in the chat. Alexia and I will be fielding those questions, and then we can make sure that Dr. Oji responds to those questions at the end. So yeah, that's kind of the agenda. Also, at the very end, there'll be an opportunity. We have a special guest joining us, Ms. Terry Kimball, and she is going to go through the top 3 mistakes to avoid. So, and you'll also have an opportunity. Everybody likes being getting a little reward along the way. We're going to reward some of the participants today with a Starbucks gift card. So be sure to stick around to the end and find out how you can get that Starbucks gift card. So I think that's about it for the admin of tonight's webinar. I would like to take a moment to introduce our speaker tonight. I've had the opportunity to get to know Dr. Oji for multiple years now, and I am so grateful for the professionalism that she brings to every atmosphere. She has earned her master's at the University of Texas Health Science Center in Houston and her doctorate from Duke University in North Carolina. She is currently a family nurse practitioner. She applies her extensive simulation education background in the classroom to teach excellent and precise hands-on skills. Her passion is helping advanced practitioners and students build confidence in learning procedures and clinical skills. She is a follower of Christ, and her worldview is based on her biblical principles. I know that Dr. Oji has helped hundreds of practitioners go to the next level in their careers, and I am thrilled to share her with you today. But before we turn it over to Dr. Oji, I want to introduce you to Alexia, who is part of the NP Skills team, and she is going to give you a greater picture of the organization and what you get to be a part of tonight. So I'll turn it over to you, Alexia.
Thanks, Kelly, and thank you for that introduction. So hi, everybody. First of all, just thank you all for coming to take time out of your day, in spite of the technical difficulties that we're having a moment ago. But we appreciate the time that you're taking out to kind of further your education and see a little bit of what we have to offer. So just a little bit about us, the NP Skills Made Easy team. Our mission is that we empower nurse practitioners, physicians, assistants, and striving NP students to learn concrete, relevant procedural skills to practice confidently in healthcare settings. And then our vision is to revolutionize advanced practitioner continual education practices by providing excellent, useful, and accessible Uh-oh. Educational content, leading with integrity and passions for excellence. So our overall like journey that we want to accomplish with you all is to get you guys to a point where you have the confidence and the skills that you need to provide optimal care to your patients, as well as share your knowledge that you have learned and your experiences that you learned with us, with other colleagues and nurse practitioners as well.
Right.
And so here are just some of our multiple nurse practitioners that we have helped out. We have over 6,000 and counting that we have helped out. As you can see, there's a bunch of big smiling faces. So we do offer a lot of interactive learning activities that you can do either online or in person. And as mentioned, we just encourage you that you share this experience with others so we can help continue the education across the board for all nurse practitioners.
It's nice.
Great. Before we get started, I just want to lay some ground rules for today. So please reduce the distractions around you. And we encourage you, as I mentioned, to stay till the end because there will be that special 3 mistakes to avoid for urgent care providers. And there will be opportunities at the end for some special live discounts as well as opportunities to get some Starbucks gift cards. So we know that the whole webinar will add so much value to you and we don't want you to miss a minute. So 3 quick things. This is going to be interactive and fun. Take a deep breath. This is not a high stress environment. We want you to be able to soak up everything that Dr. Oji has to share. So take a deep breath. And we invite you to be present. And then we're going to learn a lot, but don't worry if you have questions at the end, as I mentioned, drop those in the chat. And I'll let you know at the end as well where you can get more info and wrap up with that special offer. So I want to hear from you. So if you can drop in the chat why you are here. And I am having, oh, sorry about that. Okay, I'm just going to do it for a moment this way. I am a new grad and transitioning and will need extra urgent care skills. So that's 1. 2, I have not worked in urgent care setting, but would like to learn new skills. Or 3, I work in an urgent care setting and would like to test my skills. So let us know where you fall. I see the chat filling up. Fantastic. Okay. Great. Well, we're so glad that you're here, regardless of the reason that you're here today or what brought you here. We're so glad that you're here with us. I am going to just... I keep moving this around to be able to see my full screen. There we go. Everyone can succeed. This is a Jane Goodall quote. What you do makes a difference, and you have to decide what kind of difference you want to make. And Dr. Oji is going to take the next half hour or so to dive in to show you some specific hands-on skills in which you can apply and truly make a difference. So thank you for being with us today, Dr. Oji. We greatly appreciate it.
Well, thank you so much, Kelly. And thank you, Alexia. Thank you, everyone, for joining us, for making time. I know that, I mean, you could be finishing your chat tonight, but you made some time out to be here with us. So I really appreciate your time. So here are some questions that I want for us to kind of think about while we get started with the presentation for tonight. Do you feel confident performing urgent care skills and techniques? And of course, you can go ahead and put your answer in the chat box. Do you feel prepared to perform clinical skills in your urgent care settings? Are you prepared to see patients on day 1 in your urgent care clinic? Do you know the pitfalls to avoid in urgent care settings? So again, feel free to, make a note, answer, and hopefully by the end of tonight, we'll be able to answer, we'll have a Q&A at the end, of course, and we'll be able to hopefully answer some more questions. All right, so the 3 tips that you'll learn today would be tip number 1, sutures. So we want to make sure that we teach you how to select the right suture material. We want to make sure that we're talking about your optimal suture techniques to provide hemostasis. And of course, whenever your patient's coming, they're really looking for that cosmetic outcome. So you want to be able to identify how to, insert those sutures in such a way that you have that best cosmetic outcome. And then, of course, we want to make sure that you learn the key assessment skills and clinical decisions about when to refer. So the tip number 2 would be incision and drainage of abscesses. We want to make sure that you learn how to choose your broad spectrum antibiotics, how to learn incision and drainage for abscess principles, and then, of course, the pitfalls to avoid with your incision and drainage of abscesses. And then thirdly, we'll talk about your toenail removal. Again, some of you, I know that I have students that say, well, Dr. Oji, I do not like toenails. So we're going to talk about that today. We'll help you discover some techniques that would be worth your while, your assessment skills, and then, of course, help you select the appropriate techniques and materials to use whenever it is that you're performing your toenail removal. And then, of course, we'll review some toenail removal pitfalls that you want to avoid in your clinical practice. All right, so today's goal would be to teach you some urgent care tips and tricks to help you move forward in your NP career. We'll want to provide you with some valuable resources that would help you simplify your role as an urgent care provider. And then, of course, lastly, we want to introduce you to the Urgent Care Practice Ready course. It's a self-paced learning material that would go more in depth with all the skills that we're going to talk about today. And then, of course, I'd like to also discuss with you related to our hot tips. We have some hot topic Urgent Care Practice Ready course that is coming up in the next few weeks. So we want to make sure that you're also aware of that. All right, so some statistics that would be helpful for us to kind of talk about just to get started. So with urgent care, you know that if you're an urgent care practitioner, that you're bridging the gap between primary care and emergency care. So you're providing evaluation and care for urgent care patients, but these should not be your emergent conditions. So your job as a practitioner is to be able to differentiate a patient that should be taken care of in the urgent care setting versus a patient that should be referred out to a specialty or to the emergency room. So you definitely want to know that there are currently 14,000 urgent care centers here in the United States. In that COVID-19 era, 2019 to 2020, there has been a 7% current growth rate. Many of your patients were just seen for the first time in urgent care settings during that COVID era. So pre-COVID, a single urgent care center saw about 32 patients per day on average. With COVID, there were about 60% increase in patient visits. So you can see that with COVID, things really turned around in the urgent care settings. And sometimes you wonder why the urgent care is so busy. It's just COVID that really did, make urgent care so visible to providers and, of course, to patients as well. All right, let's kick off and talk about tip number 1. So how do you choose your sutures? So that would be a question that I get all the time from my students. I actually would get some questions on, Facebook and social media about, how do I choose the best suture material for a patient? So before we get started with choosing your suture material, I definitely want to talk about your laceration repair and anesthetics, because you want to make sure that you're keeping patients comfortable before even starting to suture, right? So the goal of laceration is really to achieve hemostasis. You want to decrease infection, and you want to provide the best cosmetic results for the patient. So choosing your anesthetic solution is so vital. You want to know the different types of anesthetic solutions that we have available. Lidocaine would be one that is very popular. So you have your 1% lidocaine, you have 2% lidocaine, and 0.5% lidocaine. We also have lidocaine with epinephrine. Again, with lidocaine with epinephrine, that would be really excellent for patients that maybe are on blood thinners, patients on aspirin that would bleed quite a bit when you make an incision, or if a patient comes in with a laceration that needs to be repaired. And then lastly, we have bupivacaine, that would be Marcaine. So I just want to talk a little bit about this anesthetic solutions, just knowing that lidocaine with epinephrine cannot be used in your digits. So the way that I teach this to my students would be anything that dangles. So you do not want to use lidocaine with epinephrine because of the vasoconstrictive properties that epinephrine has, and you do not want to use those on the digits. So anything that dangles, I say the nose, the ears, the fingers, the toes, the penis, the scrotum, you do not want to use lidocaine with epinephrine because of the necrosis that can occur with that epinephrine added. All right, so tip number one, sutures. How do I select the correct and the right suture material? So a patient comes in and you have to make a decision whether to use your non-absorbable suture, for example, your silk, nylon, or Prolene, or to use your absorbable suture like your monocryl, vicryl, or your chromic gut. So with your non-absorbable sutures, what you're really looking for is applying the sutures in the peripheral. So that would be your epidermis and the full thickness of the dermis, okay? That's where you're placing the sutures with your non-absorbable sutures. With the absorbable sutures, some examples would be monocryl, vicryl, and chromic gut, okay? Absorbable sutures, we place those on your deep dermal, for your deep dermal suture. So think about patients that come in and they have a deeper structured lacerations that you have to repair. So one thing that you want to make sure that you are mindful of is that when you're choosing the material, that you know exactly what the laceration looks like. So if it's a deeper laceration, you want to choose your absorbable suture. If it's a laceration that is not so deep, then you want to use your non-absorbable sutures. All right, I really like this slide because I know it looks a little busy, but it tells you the criteria that you need to think about whenever it is that you're choosing your suture materials. So you want to think about the tensile strength. You want to think about a good nut security. So how am I able to put in those throws when I'm putting in the sutures to get a good nut security so that that nut doesn't dehisce? And then, of course, you want to think about the workability and handling, low tissue reactivity, and suture material, a needle that is able to resist bacterial infection. So most of your suture materials, they're coated with some antimicrobial. And of course, that would help with helping to resist bacterial infection. But you want to know that if you have, and again, I always give this example to my students, in a clinical setting, even on the floor, if you have an 18 gauge needle or a 27 gauge needle, you know that an 18 gauge needle is a thicker gauge size than a 27 gauge size. So same thing with your suture materials. A 2.0 gauge size material, the needle, is going to be thicker than a 5.0 needle. So whenever it is that you're thinking about cosmetic outcomes, you want to use a 5.0 needle because that would be a thinner gauge size, and that would help with to avoid the scarring in these patients. And I can give you an example. Your plastic surgeons will use, let's say, a 5.0 or a 6.0 just really for the cosmetic results. So moving on, again, I kind of put the slide here so you can see the optimal suture techniques to provide hemostasis and best cosmetic outcomes. You want to use a 5.0 on the face needle, and you want to use a 2.0 on the plantar surface of the foot. Or if a patient has, let's say, a really thick skin, then you want to use a smaller gauge size like a 2.0, okay? So again, think about it whenever it is that you're trying to choose that suture material, what part of the body am I trying to repair that laceration? And then you choose based on the suture, the needle size. So the needle size 5.0 would be better for cosmetic outcomes on the face, on your upper arm. And of course, your 3.0, 2.0 would be a thicker gauge size, and you want to use that on the lower extremities. And then, of course, we talk about the technique. So here we have your simple interrupted and your running techniques. Your simple interrupted will be your bread and butter. Your running technique as well. We use those for the scalp. Your simple interrupted, you can actually use it anywhere on the body, on the surface. And then, of course, we talk about your mattress sutures. We have your vertical and your horizontal mattress sutures. And then lastly, we talk about your subcuticular sutures. For those of you that have attended our workshops, we call this the Gucci suture, because with your subcuticular suture, all your sutures are buried in the dermis. So you definitely want to know about that. The subcuticular sutures, we use those for very great cosmetic outcomes on the face, on the upper arm. We use the subcuticular sutures even for perineal repair. So the midwives, the OB nurse practitioners, we will use those for perineal repair. So again, it gives you the best cosmetic outcome. But I know that in urgent care settings, whenever I work in urgent care, the most common technique that you use would be that simple interrupted suture and the running sutures. All right, so this is a very critical slide that I wanted to discuss with you because this would really make a difference for you to select, make a clinical decision about who to refer out or who to actually treat in your clinical practice. So the first thing that I want to make sure that you are looking at is to perform a key assessment before this patient, before making a decision whether to repair the laceration or not. So assess for muscle or tendon, okay? How do you assess for muscle or tendon in a patient that comes in? You always want to think about the range of motion, okay? Is the patient able to move, of course, that extremity? That's number one. But secondly, are they able to push against resistance? Okay. If a patient is not able to push against resistance, then you want to have a high index of suspicion that they could have a muscle or a tendon injury. And then secondly, you want to think about a nerve injury. So a patient that comes in and they have what we call, they say, well, have pins and needles. Always think about the nerve injury. If a patient says, well, yeah, I just feel like I have pins and needles all over. Or if I have, let's say the patient has an upper arm laceration, but they have pins and needles to the distal portion of that extremity, then you want to suspect that it could be a nerve injury and you want to refer the patient out. Same thing with your vascular involvement, a patient that comes in with a laceration that wouldn't stop bleeding, you definitely want to make sure that you're referring the patient out to general surgery or to plastics, okay? I want to make sure that we talked a little bit about your lip laceration. So lip lacerations would be when you're really thinking about covering this patient. Make sure that with the lip lacerations that you're thinking about lining up, especially the vermilion border. If you're not able to line up the vermilion border precisely, then please send the patient to plastics because again, that scar would be there for the longest time. And then of course, with lip lacerations, make sure you're covering them with prophylactic antibiotics like clindamycin and amoxicillin. Those two would cover for oral flora. And then of course, prescribed Peridex rings. This is always beneficial for patients that come in with any type of mouth or lip lacerations. And then we can talk a little bit about your bite wounds. Make sure that you're not closing your bite wounds shut, okay? That's really important because a bite wound is contaminated with bacterial. It is a bacterial infection. So whenever it is that you suture a bite wound, what you're really doing is that you're trapping all that bacteria in that wound, and you don't want to do that. So you want to make sure that you are leaving that wound open to ooze. You cover the patient with some antibiotics, and the drug of choice would be augmentin. So hopefully you all are familiar with that. And then, of course, for patients that have lidocaine allergies, we can use Benadryl IM, so that would be intramuscularly applied. Please don't use Benadryl over the counter. That's not what I said. Benadryl IM has to be a formulation from your pharmacy. And that would be for patients with lidocaine allergies. So again, they have to have true lidocaine allergies. And then I do want to talk about watching out for lidocaine toxicity. So patients that come in with lidocaine toxicity would be that you have exceeded the amount of lidocaine that is tolerable in this patient. And I can give you a little idea of what that looks like. So for your lidocaine, the amount you want to use is really 7 milligrams per kilogram. So you have to calculate out that dose. Once you exceed that dose in a patient, so again, you have to calculate 5 milligrams per kilogram per dose for lidocaine. Once you exceed that dose of 5 mg per kg, the patient could have lidocaine toxicity. So again, they could end up having seizures and cardiovascular events. So you want to be mindful of that. And then you also want to watch out for patients with red hair. So this would be true red hair patients. They take twice as much to get numb. That is important for you to know. And these patients are more susceptible to lidocaine toxicity. And then lastly, you want to refer wounds that are greater than 24 hours. And the way that I teach this to my students is I say, well, from the face and the scalp, you have up to 24 hours. The lower extremity everywhere else would be 12 hours. So 12 hours will be your threshold, 24 hours for the face and the neck, okay? And then, of course, patients that come in with any type of muscle, fascia, or abdominal wounds or tertiary wounds, you want to send them out to general surgery, okay? All right, so that is tip number one for your suture. We're going to move forward and talk about tip number two, and this will be for your incision and drainage of your abscesses. All right, so what is an abscess? And I'm sure most of you know this already. An abscess is a collection of pus. It would have a painful swelling with induration. Patients would have a central fluctuant. So you want to be able to identify what a skin abscess looks like. The two microorganisms that are responsible, or you want to think about for skin abscesses, will be MRSA and strep. So it's important that whenever it is that you're performing an incision and drainage, that you're also thinking about covering this patient with a broad spectrum antibiotics, okay? Another pitfall that I want to kind of talk about right here would be opening up cellulitis and not an abscess. And that's why it's crucial for you to know that if a patient comes in, that you want to assess the patient and be sure that it truly is an abscess. So it has to be a collection of pus. It has to be painful swelling with induration. And it has to be, the abscess has to have central fluctuants before you open that up, okay? Again, precautions of you don't want to open up abscesses on the face. Think about the face with the cosmetic outcomes. And then, of course, abscesses on the breast, the hands. The hand is your money maker. Be real careful with opening up abscesses on the hands, especially the felons. And we'll talk about the felons in the next few slides. The felon is what we call the fat pad abscess. You don't want to open that up in your urgent care setting. Any abscess on the genitalia, so the scrotum or the vaginal wall, Bartholian cyst, you have to be real careful. And you want to know that you have experience, in incising and draining those abscesses before going ahead to do that. And then, of course, extensive, large, deep abscesses, you want to make sure that you're sending them out to general surgery and that you're not trying to open them up in the urgent care settings. All right, well, the technique that would be important for us to kind of talk about, and I did put this technique here because I see a lot of new grads that have abscesses that, after a few days, a patient comes in and they still have an abscess that wasn't properly drained. So I wanted to make sure that I discuss the technique here. So of course, you want to don your gloves. This is a non-sterile procedure. You want to cleanse that affected site with your antimicrobial, anesthetize the skin, so lidocaine with epi or lidocaine, plain lidocaine or marcaine. And then, of course, you want to use a number 11 blade because that would give you the most bang for your buck. The number 11 blade, and have a picture right there for you, has a really sharp edge, and it would get into that abscess. Every single abscess has a pocket, so think about it that way. Every abscess has a pocket. So your job is to make sure that you go into that pocket and make a nice incision, go deep and wide because you want to prevent closures. And then obtain a culture, and that is the standard of care, even in urgent care settings. I've done urgent care, so I know. I know some urgent care in the ER, they don't like to do cultures, but you have to always consider that, especially for your diabetic patients, patient with any type of immunocompromise, that you're obtaining a culture, send that out, because sometimes you may have to switch this patient's antibiotics. And then, of course, we insert some packing gauze, really just to keep that abscess draining for the next 24, 48, 72 hours, and then apply dressing and follow up closely with these patients, especially, again, your immunocompromised patients. All right, so some pitfalls that you want to avoid, follow closely and wound culture with your diabetic patients. your HIV patients, I know we always think about getting an A1C, but also think about getting your patient's HIV status. I've had a patient personally that didn't know they had HIV, but what had happened was that the patient had recurrent abscesses, and the only way that we found out that he had HIV, the patient did not even know that, was just because of a recurrent abscesses. So we did get an A1C, and again, get the HIV status and lab results on this patient, and we found that he was HIV positive. So always think about that as well. And then you want to prescribe analgesics for the patients, because INDs would always be very painful. And then, of course, follow up with the patient, just like we talked about, for dressing change in the first 48 hours. Dressing change, look out for cellulitis. Sometimes the patients would have what we call outpatient antibiotic failure. So you want to make sure that you're following up, and you may have to send the patient to the ER or to an inpatient setting to get some IV antibiotics. And then any type of new onset fevers, you want to make sure that you are telling the patient to let you know as soon as possible. And then you want to make sure that you're also following closely for in abscesses in patients with serious underlying comorbid conditions. All right, let's switch gears a little bit and talk a little bit about spectrum of antibiotics. So again, when we talk about your coverage for MRSA, please be mindful that Keflex is not going to work. Keflex is a first-generation cephalosporin. It has activity against just gram-positive bacteria. It has no activity against MRSA. So again, that's why it's important that you get your wound culture, because Keflex is not going to work if a patient has MRSA. Okay, so Bactrim, so that would be your TMP SMX, or clindamycin, or doxycycline, plus your incision and drainage, rather than incision and drainage alone, is a standard of care. Okay, so I wanted to make sure that everyone in the room is familiar with a broad spectrum antibiotic. So those three would be Bactrim, clindamycin, and doxycycline. So Keflex alone would not help. Okay. All right, so some more information that you would want to know about your incision and drainage. Be sure to cover for MRSA. Linezolid would be an IV antibiotics that may have to, the patient may have to receive, but that would be in the inpatient care settings, because again, in urgent care, unless if you work in an urgent care where you will give IV antibiotics. So the orals would be the clindamycin or doxycycline and Bactrim, like we talked about. Linezolid, and I see vancomycin, again, that would be a patient in your inpatient settings and not in urgent care. And then, of course, make sure that you're ordering labs for A1C and HIV, and then make your incisions deep and wide. Once you make an incision, make sure that you use a curved hemostat to break up what we call loculation. So loculation will be that pocket that I told you that every abscess has. You want to make sure that you get to it with your number 11 blade. But even once you're done with that incision, make sure you use your curved hemostat, and you go at 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock with your hemostat and break up all the loculations. And then, of course, as we talked earlier, refer patients out with large, extensive, deep abscesses to general surgery. And then, of course, any abscesses on the breast, face, and abdominal cavities, again, make sure you're referring those patients out. The reason why this is important is that they're just really high liability areas of the body. Think about the breast or the face. If a patient has some scarring, or if anything ever goes wrong with that abscess. And then, of course, the abdominal cavity comes in layers. So you want to be sure that you are referring the patients out and you're not trying to open that up yourself. Here, I want to talk a little bit about felon. A felon would be an abscess on the fat pad. So you do not want to open that up, because your hand is your money maker. I say that to my students all the time. With the hand, you can cut open a nerve or a tendon really easily when you're trying to incise a felon. So a felon would be that abscess again. Make sure that if you see a patient that comes in with a felon, that you're sending them to a hand specialist and you're not opening that yourself. All right, now we're going to move forward to your tip number 3. So now we've talked about your sutures, we've talked about your incision and drainage, and now we're going to move forward to tip number 3, your toenail removal. I always have students that say, I do not like toes, Dr. Oji. I hope you're not one of them. I hope that you're helping your patients that really need that ingrown toenail to be removed, that partial nail avulsion to be completed. But let's talk a little bit about your ingrown toenail. So the reason why most of your patients come in with ingrown toenail is really as a result of poor fitting shoes. Sometimes they have improperly trimmed nails like your diabetic patients. And then of course, hyperhidrosis, which is sweating. So think about those patients that are maybe construction workers, patients that are steel toe boots the whole time, they're susceptible to ingrown toenail. So if not treated, those patients would have pain, difficulty walking. It could result in an infectious process or drainage. And so they would come to see you because they're not able to walk. All right, so we're just going to discuss the techniques and we'll talk about the assessment tips that would be helpful for you. So we do have, make sure that you're numbing the patient that using a digital nerve block. So remember that we had talked initially about your peripheral nerve block, that would be for your sutures. For your toenail, we're using you want to numb the digits. That's really what you're doing. So you're performing a nerve block. We use the web space block for your hands. So that would be the dorsal approach. And then, of course, we use a three-sided digital block. And with that, what you're numbing is really the dorsal nerve bilaterally, and you could numb the plantar nerve, and that would be for the foot. So remember, web space block will be for the hands. So you're numbing the dorsal nerve and the palmar nerve for the hands. And with a three-sided digital block, you're numbing the dorsal nerve and the plantar nerve, okay? So some tips that you want to know is that you'd never want to use lidocaine with epinephrine for your digits, because we kind of talked about that earlier. Necrosis could occur because those digits are really small surface areas. And then, of course, epinephrine has vasoconstrictive properties, so you want to be mindful of that. You want to make sure that you're using just lidocaine with epinephrine. You're using just plain lidocaine or marcaine. So it's going to be lidocaine, no epi, or marcaine. So marcaine, bupivacaine has a longer half-life, so it would last a little longer for you if you're wanting to use that for your nerve block. Avoid using a ring block approach to avoid necrosis. So again, the technique that you want to use when you're performing your digital nerve block is what we call the three-sided digital block, where you're going to the two sides of the dorsal nerves, and then you're going across from the medial side of the toe to the lateral side of the toe. You do not want to go to the plantar aspect of the toe because of the necrosis that has been well documented with the ring block approach. And then, of course, for your toenail management, we use what we call the non-surgical therapy or the lateral partial nail avulsion, where you're going in and you're trimming at least the partial nail avulsion, you're going in and you're trimming about 30% of that nail. And what you're really doing is separating the lateral nail fold from the skin adjacent to it that is causing all of that infectious process and the inflammatory process. With the non-surgical therapy, what you're really doing, you can put in what we call a cutting gauze or cutting wool approach. Again, what we're trying to do is really separate that lateral nail fold from the skin adjacent to it that is causing all that inflammation and infectious process. So those will be the two types of techniques that we'll use to perform a partial nail avulsion or the non-surgical therapy where you're just separating those two, like we talked about. Some more tips that will be important for you to know would be updating the patient's tetanus status. Make sure that you're using the guideline for that. And then, of course, applying phenol 80% directly to the nail matrix for chemical ablation for patients that are coming with recurrent ingrown toenail. So again, phenol is very caustic, so you want to make sure that you're applying it directly to the nail matrix, that you're not applying it like nail polish when you are performing a chemical ablation. All right, so some more things that you want to know for your toenail removal. This would be some tips and tricks. Assess patients for vascular compromise and Raynaud syndrome. So hopefully you're assessing the patient, asking questions, gathering very good history before even trying to perform a nail avulsion, okay? A partial nail avulsion. Use phenol or sodium hydroxide for nail matrixectomy. if you're not confident in performing the skills and the patients or podiatry clinic. I want to talk to you a little bit about retroonychia. So retroonychia is really ingrown off the base of the nail plates into that proximal nail fold. So remember how I told you about your onychocryptosis, which is your ingrown toenail. Typically, we find that on the lateral aspect of the toes, right? Both either side. So the lateral nail fold. With retroonychia, it is really the ventral aspects of the proximal nail fold. So it's going to be just right at the proximal nail fold that the patient has the ingrown toenail. So you would find that they have a lot of the infectious process, the inflammatory process, the erythema, the granulation tissue. They have that instead of having on the lateral aspect, they would have it on that proximal nail fold. So the definitive treatment for retroonychia is total nail avulsion. Once you assess this in the patient, you're not confident with avulsing the whole toenail, then you want to send the patient to a podiatric clinic. And then, of course, you want to refer patients with vascular compromise and retroonychia to podiatry, because that would be important that you're not the one taking care of these patients. So that would be tip number 3. All right, I'm going to hand back to Kelly. Kelly, I think you have a poll before then.
Yes, thank you so much. I am going to transition to the, oh, there we go. Thank you so much, Dr. Oji, for going through all of those specifics and giving us those tips and that insight. So valuable. I know we already have some questions in the chat and we'll get to those shortly, but I wanted to just take a quick poll and see where everybody's at. So in your chat, can you let us know how confident are you in understanding referrals for incision and drainage? Once again, how confident are you in understanding referrals for incisions and drainage? So 1, I do not feel confident. 2, I feel somewhat confident. 3, I am very confident. And I'm going to open the chat so I can see. Okay, a lot of 2s and 3s. Anyone else brave enough to share? Somewhat confident, a lot of somewhat confidence. Okay, very confident. So this is just what we went through tonight is just a taste of what the urgent care course offers. So if you feel somewhat confident but want to increase your confidence, I would highly encourage you to join us for the urgent care course. This is one of our top selling courses. It includes a 1-hour instructor-led suturing class. You receive practice suturing materials at your location, and you will earn 27 continuing education hours and 16 RX hours upon completion of this course. This is a phenomenal opportunity to ask the clinical instructors questions to succeed in your clinical practice, and there's some valuable networking opportunities. So, what's included in this course? 1, urgent care skills and procedures. 2, common urgent care disorders, infections, and treatment modalities. 3, pediatric and adult urgent care issues. 4, urgent care treatment and management. And 5, urgent care document and role of the advanced practice practitioner. So this is a very comprehensive course. A few other details. Oh, I'm going to actually share this little video from one of our students, and then we'll get to some more of the details.
Hello, my name is Alexandria Jackson. I'm a nurse practitioner, and I recently enrolled in the urgent care program online, and I can honestly say that I am amazed regarding how many gems are packed into the course and how well built the course is. I actually am engaged and ready to learn when I log on. I'm definitely amazed at how much information is actually packed into the short courses, the quizzes to kind of test your knowledge, in addition to the printout, like the PowerPoint presentations that are within the courses. So if you are thinking about taking this course, stop thinking about it, just do it. It's an investment in yourself and it's an investment in your future, and you will definitely grow professionally.
Great. Thank you, Alexandria. So was everybody able to hear that? Good, great. I think it's really valuable to hear from others that have traveled the path before you. Here's a few more testimonials. I'll give you a moment to read them. But it's just so valuable to know that there have been hundreds of students, over 300 students that have not only taken this course, but gotten their continuing education hours and have gained so much knowledge for their practice. So other courses that NP Skills offers is women's health, X-ray lab, EKG, family practice, and a whole bunch more. I think that Alexia might drop some links in the chat, but we wanted to give you a very special offer tonight. This is available until midnight tomorrow, and we want to offer 25% off our urgent care course. So normally the price is $647. If you just went to our website right now and added it to your cart, it would be $647. But if you use the code webinar25, you'll be able to access the course for $479. Plus, if you register today, you'll also receive a $20 Starbucks gift card and our popular laboratory interpretation cheat sheet. So we're going to drop that link in the chat once again. You can also scan this QR code. If you're on your phone, it might be a little bit more challenging, but if you're on your computer, grab your phone, scan that QR code. And we want to give you this $20 Starbucks gift card just as a congratulations for making the decision to invest in your skill set. And maybe you can enjoy a few cups of Starbucks while you study. So that is for you. I'm going to turn it back over to Dr. Oji, who's going to introduce our special guest. And I will be back for Q&A in just a few minutes.
All right, so I do have a special guest, Terry. Terry is here. She's an urgent care nurse practitioner. Terry and I, we go way back. I actually was her instructor at NP school. And we just wanted to introduce Terry to you, and she would tell you about the top 3 mistakes that she has seen in urgent care practice that urgent care providers make, and hopefully that you can avoid those. So this would be straight out of Terry's experience from the urgent care settings. So Terry, do you want to, you can go ahead and.
I don't know, can you see me or can you hear me?
We can hear you. Yeah, we can hear you, Terry. So you can.
Okay, I can't figure out how to do my camera.
That's okay.
Is that okay? Just talk.
Yes. Yes.
Okay. Well, I'll just say that I started off in family practice and I wanted to go to urgent care, and I had an opportunity to do that. And I had to confess to the doctor that I did not feel comfortable doing procedures, that I had not done any in family practice, and that I wasn't his girl, but I sure wanted to learn so that I could be there. So I took the urgent care course and I went to the skills lab, and then I felt completely prepared. And I honestly went in and felt so confident. When the first time I did my first toenail remover from the skills lab, I remembered that rubber toe and I just did it. And I'm just very thankful for it. But I have to tell you a really wonderful thing that I learned. I've been a paramedic for many, many years, 30 years. And I've had a lot of 12 lead courses, but I always struggled with 12 leads. And this 12 lead portion of the urgent care course was amazing. Definitely the best I had ever been a part of or seen. And I was able to use a portion of that helped with one of my patients. This patient came in with he was just a little bit hypertensive and a little dizzy. And we did a 12 lead on them, and I couldn't really, the anterior leads were rather subtle in elevation, not very much, but I had learned about the Pell's mnemonic. and how I could look in those reciprocal leads and see for depression, and it was there. I saw depression in 2, 3, and AVF. So it confirmed that there was something going on in those anterior leads. So we immediately sent him to the ER, and their 12 leads showed definite ischemia in the anterior part of in the anterior lead. So I'm just so thankful that I was able to use that portion. And I copied a lot of the information that I learned from the course. I put it on index cards, and I just keep those with me right in my drug box or right in my pocket. And they've just come out so handy. I'm just so very thankful for this course. So you want me to talk about 3 pitfalls, mistakes?
Yes.
Is that what I need to talk about? Okay.
Yeah, that would be great.
So
Kelly, can you move on to the next slide so folks can get the link if they wanted to register? Sorry, Terry. Okay.
No.
Yeah. All right. Yeah.
yes, definitely do it. It is a big confidence booster.
All right, Terry. Are you ready to go?
Oh, okay, about the 3 pitfalls
Yes.
that I've experienced.
Yes.
One of the pitfalls that I've seen, and I still consider myself to be new, and I'm definitely learning because I've only been doing family urgent care now for about 6 months, is not referring to the properly. And I had an experience with this where a patient came in. It was a young boy that was playing baseball and received a blow from a baseball to his face and had a nosebleed. And the nosebleed had subsided, but he still complained of some throat bleed. He felt like he could taste the blood. And I told the mother that I was concerned because, of course, the ball to the face was very concerning. I also told her I was concerned about a posterior nosebleed because of the fact that he can taste it, and I couldn't help her with the posterior nosebleed. So I wanted her to go to the ER and get a CAT scan. She just said, no, I really don't want to go. He's already had CAT scans before with other things, and I just don't really want to go. So I went ahead and I did it myself, and I ordered the CAT scan. And anyway, it didn't turn out very well. She ended up having to go that night to the ER because the boy had a posterior nosebleed. And it just showed that I just tried to take care of something in my gut. I knew he needed to go, and I allowed my judgment was impaired by trying to please the mom. Another pitfall that I have found is just poor communication breakdown, provider-patient breakdown. You just have to I've learned that you just really have to zone in on that. That is so important. And watch out how you say things. Sometimes you'll say something and it comes out wrong. Like one lady came in and she had a laceration on the part of her thumb that she really needed. It was in a real awkward space, and I really wanted it to be immobilized so she could keep it from bending it to tear the sutures open. And I just told her that that there wasn't a splint that I could put on there. Well, she took that as we didn't have the supplies we needed. And actually, I don't even know that they even make that type of splint. It was on an awkward portion. So that kind of thing, just be careful some of the words where you explain things. Another thing is one of the things that I have noticed is there's missing charges, not being able to code properly, miscoding something. It really does neglecting to properly account for charges leads to financial losses. And so I've noticed that I have to really pay attention to that. We get so patient focused. And in my family practice world, it was a clinic where it was for needy population. So I didn't even have to know codes hardly. And so I was out of practice. And so I really had to learn that portion, and I'm keeping ICD-10 app right by me and making sure that I do things right. And then don't forget on those procedures, all the little things about the codes. But so those are just a few things that I've learned. Still learning, have so much to learn, and just so thankful for Dr. Oji and her world of helping us. I wished we could have all gotten this in NP school, but I know that we have so much to learn. So anyway, that's just a little bit that I'd like to share.
Thank you so much. Yes, go ahead, Dr. Oji.
No, I just wanted to say thank you, Terry. That was really well thought out, because you know that in urgent care it's just fast and furious and you have to make quick decisions. So I'm glad that you could share your heart tonight. Thank you, Terry.
Yes, thank you so much, Terry. We're going to
You're welcome.
transition to our Q&A section. I saw that there were some questions. I'll try to address those. We'll leave this up just for a couple more minutes. But I want to just start with a few questions that I saw through the chat. And first question is there a payment plan to purchase the urgent care course? Dr. Oji.
Yes, there is a payment plan. So there would be for those that are wanting just to pay for the first 3 months, but they will still have a 12-month access to the course. So there is a payment plan.
Okay, so yeah, 3 equal payments,
Yes.
and you can still use the coupon as well and pay over 3 months. Great. Alexia, if you could drop the link for the payment plan option in the chat as well, that would be fantastic. If not, I can drop it there in a moment. Okay, second question. How long will I have access? You already answered that. 12-month access. And then can this promo code be used on any of your other comprehensive courses or bundles when individuals go to your website, or is this discount solely for this course?
Yeah, so we definitely, for being here, you can use the code as well. So you can use this webinar 25 code for other courses, not just the urgent care course. So yes, and you still receive the Starbucks gift card.
Beautiful. Okay, Alexia, do you want to jump on with us? Did I miss some of the questions in the chat? I know that I was engaged in the slides, and I just want to make sure that I didn't miss any of the questions that were addressed to Dr. Oji.
I believe she answered the one about the sizing of the sutures, about like what would be the proper needle to use based off of the thickness of the patient's skin. Dr. Oji, I think you answered that already.
Yeah, I did. And maybe just for everyone's benefit. So if you have a patient that comes in with a thicker skin, so let's say the plantar surface of a foot, you want to use at least a 2 gauge size or 3 gauge size. So it has to be a thicker needle so that you're able to take a good bite when you're suturing that laceration. If you use a smaller gauge size needle, that can break. So you want to be really sure that you're using a good size needle to be able to take a good bite.
Okay. See a couple more questions coming in the chat here. Just trying to open it. Alexia, feel free to jump in.
Yeah, I'm trying to see. It looks like somebody said they have some scenario questions. They would like to further express themselves with that.
Okay, yeah, sure.
Feel
What
free
scenario?
Sure.
Yeah, jump off chat.
Hey, Dr. Obi. I had a
Hey.
question.
Yes.
Yeah, I don't know if you remember me or not. I was the one that was venting to you about the crack clinic. I escaped that place. I'm at I'm at the urgent care now.
Very
Um,
good.
navigating the different scenarios that we end up with. My first shift at the urgent care, I ended up having a 10-year-old girl got her foot caught up behind herself down a hill and ended up being a distal tib fib fracture. Like you said, it was very important and remembered in your lecture up high to get a scan up high so we don't miss a fracture up high near the hip.
Yes.
My supervising physician didn't answer me back. I called my other buddy who was FNP in the ER, I went ahead and consulted the pediatric orthopedic doc on call. My question is, did I do the right thing in the fact that the concern was that the read wasn't too clear, but it was there could have been some involvement in the growth plate. So
Mhm.
either way, I was gonna go ahead and just try to splint it as best as I can with the immobilizer. That's all I had. We don't have any plaster. We don't have any orthoglass, and just
Right.
send them down to the ER. Was that the correct move, or was it could I just did something differently? I premedicated the patient before we went to scan. I mean, she couldn't bear weight when she came in. So
Right, right. No, I think that was the right thing you did, Top. So, if you think about it, a patient that comes in with a fracture, your job is really to get them in a splint as quickly as possible, and they need to be in a splint for the first 48, 72 hours before going in to see ortho. Because again, what we need with the splint, remember the splint is more temporary, so we need that swelling to go down a little bit before getting the patient in a cast, because the cast is the more definitive treatment option for a fracture. But you did the right thing. You really did the right thing.
so that yeah, I was freaking out because I was working in the ER as a nurse. So I mean,
Right.
I was like, where's the plaster? Where's the orthoglass? He told me he's going to teach me how to splint and all this stuff. And but I guess that's a normal thing in the urgent care, not to
Mhm.
have that and just send him to the ER. Is that correct?
Yeah. So and it depends. It really depends on where you work, and you
That
don't
is a
want them
lot
to
of
get.
gray area.
I know it is. I know.
Man.
But that's a great question. That's a very good question. So again, if it's the owner says no, you just send them to the ER, then you want to do that, right? So it depends on their comfort level too. And you also have to think about liability in everything that we do. It has to, yeah, at the end of the day, it's liability for the owner of the practice and for you as a practitioner. And so most of the time, they really don't want to have to deal with that. And that's why they send the patients to the ER.
Okay. Well, I'm sorry they're taking up
No,
time, but
that's okay. Oh, you're fine.
there's another scenario where a young gentleman, he's probably in his 20s and 30s, came in with hypoxic, did a chest X-ray. He was low grade fever. It was right middle lobe pneumonia.
Mhm,
My concern was he was sat in low 90s, maybe high 80s,
mhm.
and we gave him a breathing treatment. Obviously, he bounced back up, and I gave him PO. I think it was levofloxacin or whatnot. I forgot which antibiotic I chose, but either way, the owner wanted him to come back
Mhm,
and for a repeat chest X-ray.
mhm.
And he was, I guess, he was upset that I gave ER warnings,
Yes.
or yeah, because there wasn't any definitive red flags. I mean, I think to me that's a red flag. A young, healthy guy, and he's hypoxic like that. Or am I wrong to think that? Or
Well,
I feel,
yeah, no, go ahead. Sorry.
no, I was just gonna say I always tend to give ER warnings regardless, but I was just surprised that he said, you don't. He wanted him to come back and not hurry up and send him back to the ER. I guess I'm not sure.
So I would tell you the standard of care would be for us to repeat the chest X-ray after 2 weeks, right? So you start
Okay.
the fluoxetine, you start the antibiotic, then you want to make sure that you bring the patient back in within 2 weeks, just to recheck and make sure that the antibiotic actually cleared the pneumonia, right? But you also have to think about the fact that the owner of the urgent care wants to make all the RVU.
Under That's what I was. Yes, I wasn't trying to say that bluntly, but yes, okay, I also understand that part.
Yes, yes. So
Yeah,
so they do
yeah,
not
yeah,
want
okay.
to send in patients to the ER that they feel that they can treat over in the urgent care setting. So you definitely want to think about that in terms of anyone that you can keep in-house without sending them to the ER. That's more RVU for the practice. And as long as they can manage those patients effectively, then there's nothing wrong with that.
Okay, cool. Well, what about a paracanoikia? I guess it's the swelling of the fingertip nail.
Yes.
Um, it's okay to go ahead and start with oral antibiotics. It doesn't necessarily have to be drained versus, or would you want to if you see some fluctuance or
Yeah.
pus? Because I didn't see any. It was just red. Was that the
Right.
right decision to just try oral first?
So the oral is fine, but you may want to nick and open it up a little bit to drain, because what the thing about abscesses is that, again, especially if they're more than 5 millimeter in size, you want to be able to drain that, because if you just start the antibiotics without draining, then at the end of the day, that abscess is just going to get bigger and bigger, right? So always think about the size of the antibiotic of the abscess. If it's 5 millimeter or more, then you want to drain it and then start the antibiotics. Make sure that you're using the broad spectrum antibiotics. With paronychias, it would just be a little, your number 11 blade, a little nick, and that should drain all the purulence. Okay, so that would really help.
Yeah, I totally
Thank you, Tap.
Yeah,
It's been so good to connect with you. I do want to give a few other folks an opportunity to ask some questions, just because we do want to wrap up in the next few minutes to honor everybody's time. But I'm so grateful for your curiosity and the hunger in which you are seeking out Dr. Oji's wisdom. Obviously, you've had access to her in other courses and understand just what a brilliant practitioner and teacher she is. So I appreciate you, and I know that you'll have more opportunities to connect with Dr. Oji in the future. I saw a couple other questions come through. When would you recommend a cutting versus taper needle for suturing?
So most of your, and then, so thanks for that question. Most of your suture needles would be cutting edge, right? Versus your tapered needle. So think about, let's say, your non-absorbable sutures, your silk, your nylon, and your polypropylene. Those are all cutting. And then the taper, there are very few taper needles. So again, I know in your OR, those really make a difference. In urgent care, in primary care, we just look at the is it non-absorbable, is it absorbable, and then we use it as needed. So hopefully that helps. Did that answer your question? I want to be sure that answered your question. Diane, did that answer your question? Yes, okay.
Yes,
All
great.
right. Okay, great. Any other questions?
You can jump off chat or off of mute if you'd like. Okay. I just jotted something in the chat. If you enrolled in one of our courses tonight, please drop your preferred email in the chat so we can get you your Starbucks gift card. We're excited to be able to bless you with that. So feel free to drop your email in the chat below. We probably have a moment for, oh, the code shows invalid, Denise is saying. Is it all caps or maybe?
It's a small letter WEBINR, so webinar 25, and it should be good.
Looks like Shannon was able to register. Congratulations, Shannon. Yeah. We'll get you that Starbucks gift card in the next 48 hours. One more question from Diane in the chat, Dr. Oji. I have never tested an IND for HIV. Is that a standard of care?
Yes, so that is the standard of care, because remember, with especially with recurrent abscesses, if there's got to be the reason why the patient has recurrent abscesses, and most providers, and that's a pitfall that we see in practice, that we think about A1C, we think about diabetes, but you also want to think about immunocompromised like HIV, and that's important because again, that would be, you don't want to miss it. Again, like that patient, the example that giving earlier, the 45-year-old patient, he didn't know he had HIV. It was just the abscesses that he had that were recurrent that showed that he had HIV. Okay, so it is a standard of care, just to your point. Okay.
Okay. Well, I'm going to wrap up here with just sharing our screen one more time. What if it's single and not reoccurring is Diane's follow-up question.
Yeah, so if it's just a single, you want to start with A1C for sure. And then always think about when the patient comes back in that you want to add the HIV status. But even the new CDC guideline says that for your patients that come in for just to,
Yes.
for their annual well visits, you want to be sure that you're covering, you want to make sure that you're ordering HIV status and hepatitis C status. Again, remember that that is your standard of care. So even if it's not just for the abscess, you want to make sure that you're catching that also for your annual well visits. Okay.
Very helpful. One other question was, if we register after the webinar is over, do we still get the discount in the Starbucks gift card? I know that you still get the discount until midnight tomorrow,
Yes.
the 26th. I don't know the ruling on the gift card.
Okay, we'll just, since you were here, that's fine. What's your name? So we can get your name, and yes, we'll send you the gift card.
Beautiful. And will the class be live on Zoom to learn suturing?
Yes. So that would be a live class on Zoom. And you would have an instructor that will send you the suture materials first of all, and then you would have an instructor that would guide you step by step to make sure that you're suturing the right way, correcting, and if you have any questions, they're able to answer those questions as well.
Great. Excellent. Okay. Well, just for those of you that are maybe joining us on the recording, I want to share this just one more time so everybody can see it. Here's the QR code. Just a quick recap. This 25% off is available until midnight tomorrow, Wednesday, June 26th. And you can use this 25% off on any of the courses on the NP Skills Made Easy website. But it's only available until midnight tomorrow. Here's some contact info for us. If you have questions as to how to reach Dr. Oji and her team, this is our contact information. Feel free to take a screenshot of this and save it. If you're not necessarily in a spot right now that you're ready to take continuing education hours and dive in, you will be along the way, and we'd love to be the place that you come for your continuing education experiences. And if you like this webinar, we'll be hosting another one in September, and we'd love for you to share it with your colleagues. Anything else, Dr. Oji?
Well, I just wanted to say a big thank you to you, Terry, Kelly, Alexia, and of course, everyone else that joined us tonight. Thank you so much for spending your evening with us, and we hope to see you again in the future. Thank you so much.
Thank you, everyone. Have a great night.
All right. Thank you, guys. Bye-bye. Bye-bye.